ctDNA MRD is a very hot space. In the past, they tried to do a trial, the Mermaid 1 and 2 trials, and they were stopped due to feasibility issues because they decided to use a tumor-informed assay. And it turns out that many times you don't have enough tissue for you to create this personalized ctDNA assay. Most ctDNA assays that we have nowadays that have a better limit of detection, so that arguably would have a better sensitivity for detecting true MRD, they are tumor-informed. And the challenge that we have is that there has been a shift in the treatment of early-stage resectable lung cancer. Nowadays, we're doing a lot of chemoimmunotherapy before surgery. And between 16 to 24% of patients will achieve what we call complete pathological response. So there will be no tissue left. And then there's another additional up to 20, even 30% in some studies that will have a major pathological response. So when you have that, you're not going to have tissue. So it's not feasible, in my opinion, to use a tumor-informed assay in this space, even though they do perform better in terms of sensitivity when you look at the data of the tumor uninformed, because you're not going to have tissue, right? So that is why we are not using that in clinical practice yet, because we don't have an ideal assay. The assays that do not use tissue to detect MRD, their limit of detection are lower, so you're going to have a lot of false negatives. And whenever you see the assays, they describe the analytical sensitivity, which doesn't translate in clinical sensitivity, meaning the ability to detect disease before it actually shows up on a CAT scan, right? So the ability to detect disease recurrence using this biomarker. So that's the issue that we have now. So what we're going to be doing the next few years is designing trials where we elect one assay that, in my opinion, is probably going to be a tumor uninformed or tumor agnostic, tumor naive. Basically, you don't need tissue, and then see if you can make decisions based on that. The issue that I think for current design is that not having the data on a specific assay, we may be in a situation where we're collecting samples and then retrospectively analyzing them, just like Dr. Vokes and myself did in our separate studies, right? Those trials, they happened, they were phase 3 trials, then we got the samples and we analyzed, and then we saw the results. So it may happen that, and it may be that this will happen in the MRD space, and it will take longer for us to be implementing this in clinical practice. The other thing is that there are people already using some of the assays that are out there, but the issue is that, let's say you even have tissue after chemoimmunotherapy, after that you do the surgery, there's enough material to develop this tumor-informed assay. You're just looking at that one time point, and unlike stage 4 disease, where potentially, based on my study published last year, you could use just one time point. I think for early stage disease, it's a mistake to just use one time point to make decisions regarding additional adjuvant treatment. I think the dynamics portion is extremely important in this setting, because what we have seen so far is that some patients before chemoimmunotherapy, before surgery, they have detectable ctDNA. And these patients that have detectable ctDNA, after you give the chemoimmunotherapy, some of them will clear and some won't. So that population is composed by 2 risk groups, the intermediate and the high. For me, the intermediate is patients that have positive ctDNA that clear. And then arguably, these are the ones that I would be willing and thinking they would benefit from additional treatment because they were positive and they clear. So maybe you should be giving additional treatment. Now, the ones that remain positive after chemoimmunotherapy and surgery, I think is very unlikely that just continuing immunotherapy will help them. And that's probably the patient population that we should be thinking about escalation of therapy in the adjuvant setting. And then you have the ones that are negative before chemoimmunotherapy and surgery, and they continue negative, remain negative. And arguably, those are the low-risk patients, and they probably don't need anything else. So that's why I believe at least 2 time points are essential to guide decision-making in the setting, especially in the in the current moment where we have an option to just give chemoimmunotherapy followed by surgery, or give chemoimmunotherapy, surgery, and additional adjuvant immunotherapy.